this video, we will be revisiting the clotting cascade and the anticoagulants that we introduced back in Block 4. So in Block 4, we focus specifically on heparin, but in this video, we will review the clotting cascade and heparin, but now we will go over the other anticoagulants in more depth that can be used in the case of venous thromboembolism or VTE prophylaxis and or treatment. So we're talking about our DVTs and our PEs. So let's begin with our clotting cascade. And remember, blood is a fluid circulating under pressure. So following any sort of vascular injury, any escaping blood must be rapidly converted into a clot to plug the injury to minimize any further blood loss. So the blood plasma contains a collection of clotting factors that act together in a cascade of enzyme activation events, leading to the formation of a fibrin clot. So as a reminder, these factors are all represented usually as Roman numerals, and they are zymogens, and the addition of a lowercase a means that these have been enzymatically activated. So there are two major pathways for triggering the clotting cascade. The first one we'll discuss is the primary pathway responsible for triggering coagulation, and this is the tissue factor or extrinsic pathway. And it is initiated by tissue factor, which is a cell membrane protein that is released by endothelial cells after a vascular damage. And when it comes in contact with the blood, immediately triggers this cascade, like in the case of some kind of trauma. So this leads to factor 7 cleavage and activation, which will then bind with tissue factor to lead to the activation of factor 10 to factor 10A. Factor 10A must then combine with activated factor 5, so 5A, to propagate the cascade and activate factor 2 or prothrombin into thrombin. Thrombin can then cleave a number of other factors in the clotting cascade. To propagate this pathway, can also activate negative regulators if needed, and most importantly, cleave fibrinogen to fibrin to lead to the formation of a cross-linked fibrin clot, which can combine with the initial platelet plug at the site of injury to hopefully prevent any further blood loss. Now, the secondary pathway that we will just briefly mention is the contact activation or intrinsic pathway, which begins with plasma exposure to endothelial collagen and begins with the activation of factor 12, which activates factor 11, followed by factor 9, which together with factor 8 will funnel down to activate factor 10 to factor 10A. And thrombin activation, and essentially this activation of our common pathway. Now remember, I mentioned negative regulators of this pathway. So first we have protein C, which is an important anticoagulant that is activated by thrombin and binds to thrombomodulin and picks up cofactors like protein S to form an activated protein C complex that can degrade both activated factor 5 and activated factor 8 to turn off this cascade. And the other key anticoagulant we will revisit that we discussed a lot in Block 4 is antithrombin, which inhibits the activity of several factors, but we will focus on its activity against thrombin and factor 10A specifically in this video. Before we move on to discuss how this tightly regulated process can become unbalanced, leading to VTE, we need to first discuss the synthesis of vitamin K dependent clotting factors. So there are several factors or components of this cascade that require a vitamin K maturation reaction or activation step. So not to be confused with the cleavage of a factor to its activated form in this cascade. This vitamin K activation step is required to get from an immature clotting factor to the one that's ready to be cleaved in this pathway. So this applies to the vitamin K dependent factors 7, 9, 10, and thrombin, as well as protein S and C. Using the vitamin K supplied from the diet, for instance, a gamma-glutamyl carboxylase catalyzes the addition of a carboxyl group to a glutamic acid residue in these proteins so that they are ready to feed into this pathway and they are ready to be cleaved when needed. But this process leads to oxidized vitamin K, which needs to be returned back to its reduced form by vitamin K epoxide reductase, which is also, remember, B-core-C1 from back in block 4, which we talked about for pharmacogenetics. So once it's back into its reduced form, it can then participate in this generation of more mature clotting factors. And this will be very important for future slides. So this completes our overview of the clotting cascade, which is somewhat simplified but sufficient for our discussion of anticoagulants that we will cover in this video. So moving to our next slide. Looking at our completed clotting cascade, we know this pathway is programmed in order to prevent further blood loss in the case of vascular injury. But there are many pathologic circumstances that lead to the triggering of this cascade inside of intact blood vessels that leads to the formation of a blood clot or VTE. Or there are a number of conditions and drugs that may increase the risk of VTE. And one of the primary examples I just want to introduce really quick would be estrogen containing agents like our combination oral contraceptives. So if VTE occurs or VTE prophylaxis is needed, we have several classes of anticoagulants that hit different parts of this pathway to counteract this pathologic activation or this risk of activation for both the inpatient and outpatient settings. So now one thing before we jump into our specific agents, because we are inhibiting this cascade, all of these agents that we're going to talk about today will place the patient at an increased risk of significant bleeding events. So care will have to be taken for individuals that are at risk of falls or on other agents that increase bleeding risk. And patients will need to be counseled extensively on the signs and symptoms of bleeding. So keep this in mind as we talk about the pharmacologic considerations of the agents we're going to go over in this video, because for the sake of time, I will not mention the significant risk of bleeding events for each specific agent. So now let's move on to our first group of agents, which will hopefully look very familiar to you, and we're going to cover heparin, low molecular weight heparins, and fondaparinux on our next slide. So we will start off with heparin. Now, heparin is an anticoagulant that's used for the treatment and prevention of VTE and is very common inpatient because immobility increases the risk of VTE. So VTE prophylaxis is commonly needed on top of those that are admitted for the treatment of a VTE. So how heparin works is it is a naturally occurring glycosaminoglycan polymer of varying lengths that binds to antithrombin to promote a conformational change that increases its affinity for thrombin and factor Xa, acting as a catalyst to promote their inactivation, and this leads to the anticoagulant effect by essentially hijacking the body's endogenous anticoagulant mechanism. Now, you will likely see this as unfractionated heparin, because remember, heparin is a mixture of polymers of varying lengths. But heparin can be fractionated to yield low molecular weight heparins. Which are shorter heparin polymers and a pool of more uniform polymer lengths. So these low molecular weight heparins, like Lovenox, which is also known as enoxaparin, can still bind to antithrombin in a similar fashion, but because they are shorter polymers, they cannot all accommodate thrombin as well. So their effects lead to more specific inhibition of factor Xa with varying degrees of thrombin inhibition. And because of this more pinpoint mechanism of action and uniformity in polymer lengths, the anticoagulant effect of these agents is much more predictable than unfractionated heparins, meaning relatively less risk of bleeding and more fine-tuned efficacy. And then hopefully you remember there's also fondaparinux. that makes more sense to introduce here because it is an indirect 10A inhibitor, which contains only the minimum antithrombin binding site that is also shared by the heparins and the low molecular weight heparins, but not the long polymer structure. So this agent will bind antithrombin and act as a catalyst in a similar fashion, but now will only be able to accommodate and inhibit factor 10A. So there is no opportunity for thrombin binding or inhibition. So even more specific anticoagulant mechanism of action when compared to the low molecular weight heparins. So moving to our next slide. So before we get into the specific pharmacologic considerations for heparin, I did want to further highlight its mechanism of action and structure versus the low molecular weight heparins and fondaparinux like we did back in block 4. So remember, unfractionated heparin contains a mixture of highly negatively charged polymers that will bind to antithrombin, and then based upon the polymer length, promote the binding and inactivation of factor 10A, or thrombin. Whereas our low molecular weight heparins, which remember is heparin that has been fractionated for a shorter length threshold, the majority will only be able to promote antithrombin mediated inactivation of factor 10A, maybe some thrombin, but primarily factor 10A inhibition. And then fondaparinux is the minimum structure required for antithrombin binding, which will lead to the specific inactivation of factor 10A. Now, one reason for this fractionation and the development of fondaparinux is because heparin is either given IV or sub-Q. But if it's given sub-Q, the wide variability in size makes absorption from the subcutaneous tissue incredibly variable. So pharmacodynamic effects are very unpredictable. So we can't really use subcutaneous heparin for treatment. We have to use IV and titrate to effect because of this variability. So to ensure patients are appropriately anticoagulated, it does require monitoring, usually with an APTT, or an activated partial thromboplastin time, which is a measure of how long it takes for the blood to clot. And it should be about 1.5 to 2 times normal. And this has to be done relatively frequently at initiation and with dosing adjustments. So as you can probably guess, this agent is a narrow therapeutic window drug. We also need to be looking for those signs and symptoms of bleeding, so checking a CBC regularly. And then if significant bleeding does occur or the patient requires some sort of emergent surgery, for instance, and a heparin reversal is necessary, there is an antidote for heparin called protamine sulfate. And this is an incredibly positively charged peptide, so that it will bind the negatively charged heparins and prevent their interaction with antithrombin until they can be cleared from the body. And then coming back to our CBC, from the CBC we will also be looking for thrombocytopenia, which is critical for heparin therapy. And heparin can lead to a drop in platelets from 2 different mechanisms. In type 1 heparin-induced thrombocytopenia, or HIT, heparin directly causes platelets to aggregate, which is generally common, mild, and transient, and occurs in the first day or so of therapy. So this one isn't really the big issue. But if we have type 2 HIT, this is when heparin induces an autoimmune-mediated response after the first week or 2 of therapy, where antibodies are formed that recognize the heparin-bound platelets, leading to their activation. So you get this platelet aggregation. So we have thrombocytopenia because we're using up the platelets, and this leads to a hypercoagulable state and may actually lead to HIT with 2 T's, or heparin-induced thrombocytopenia and thrombosis, where the second T, as I said, is thrombosis, and this will lead to a dramatic drop in platelets of like greater than 50%, and this is life-threatening, and if this occurs, these patients can never have heparin again. So now that we've discussed the primary cons, let's discuss the pros of heparin therapy. So heparin does not cross the placenta because they are very large molecules, so unfractionated heparins can be used in pregnancy. And heparin has a really short half-life compared to some of the other agents we'll talk about in this video. And it spans anywhere from 30 minutes to an hour and a half. So we have quick on effects, so we're going to reach our steady state for therapy in several hours, and we have quick off effects, for instance, if there is any signs and symptoms of bleeding or if emergent surgery is necessary. And this agent is very cheap compared to many of the other agents we'll talk about. And as we mentioned before, there is an antidote for immediate reversal of heparin therapy. So now transitioning to our low molecular weight heparins, many of the things we discussed above for heparin are true, except for the fact that low molecular weight heparins are going to lead to more predictable anticoagulant effects. So this means that they can be administered sub-Q for not only prophylaxis of VTE, but now for treatment with more predictable pharmacokinetics and pharmacodynamics. And also this means that we don't have to do that frequent APTT monitoring that we would for heparin. And this also wouldn't work as well for the low molecular weight heparins because these are more factor 10A specific in terms of their mechanism of action. So because these agents are more predictable, we can do anti-factor 10A monitoring, and this can be used, but is really only needed in certain situations, like in renal impairment or if bleeding occurs, but is not routinely necessary. As for fondaparinux, very similar to the low molecular weight heparins, but will provide a mechanism of action that leads to even more specific anticoagulant effects, which is a bonus. And this can be administered once daily, sub-Q, so only 1 injection per day versus the low molecular weight heparins, which may need 2 per day depending upon the indication and the agent that is chosen, which is a bonus, especially if this agent is going to be used in the outpatient setting. So before we move on from these agents, it is very common for these 3 agents to be started inpatient and then transition the patient to one of the oral agents to continue as their anticoagulation therapy outpatient. So now let's move on to these oral anticoagulant options on the next slide. Now our first group of agents we will discuss are the direct factor 10A inhibitors. Because remember, we already hit on our indirect factor 10A inhibitor with fondaparinux. And the main difference in mechanism of action is these agents will not have to bind antithrombin to elicit their anticoagulant effects. Instead, these agents will bind factor 10A and inhibit its effects, preventing that thrombin generation and its downstream effects in the coagulation cascade. So these anticoagulants like rivaroxaban, and apixaban all share this ending, and the XA middle portion of their name should hint towards their mechanism of action. So as for pharmacologic consideration, these agents are administered orally or PO and usually are started after sufficient therapy with one of the IV or sub-Q options we discussed on the previous slide. But because these agents have a quick on and offset, these therapies do not need to overlap. So you can essentially stop your low molecular weight heparin, for instance, and start the direct 10A inhibitor at the time of the next dose, which makes discharge much easier for patients. They also do not require any routine monitoring because of their predictable anticoagulant effects, but anti-10A levels can be done in specific situations if indicated for monitoring these agents. As with many of the other agents in this video, renal dosing adjustments are necessary, but also watching out for interactions with P-glycoprotein and CYP3A4 inhibitors and inducers will be important, and cautiously using these agents with hepatic impairment as well. Now, if bleeding occurs with this agent or emergent surgery is necessary, there is now a reversal agent that is recombinant factor 10A, which wasn't always the case. And historically, this was one of the biggest downsides for these agents for a very long time, is the fact that there was no antidote. But now we do have this antidote if it is ever needed. Now, the next agents we will discuss will be our oral direct thrombin inhibitors, or our DTIs, like dabigatran. This agent acts as a competitive inhibitor and binds to thrombin to prevent its actions, leading to anticoagulant effects. So the direct thrombin inhibitors are similarly started as PO options at discharge after sufficient IV or sub-Q anticoagulation, and again have quick on and off effects, so there's no overlap needed. And discontinuation for planned surgeries, for instance, is much more straightforward. So these also do not require routine monitoring. But an APTT, for example, can be done if needed in cases of things like renal impairment or if bleeding is suspected. And this agent will require renal dosing adjustments, and care must be taken when administering this agent with other drugs that inhibit or induce P-glycoprotein. But in this case, we are not as worried about CYP enzymes. There is also a monoclonal antibody reversal agent available if needed, called idarucizumab. Now, all of these agents that we addressed on this slide were all developed to serve as safer alternatives and more predictable alternatives to warfarin, which I know we discussed extensively in Block 4, but now on the next slide we will revisit this agent and its important pharmacologic highlights. So moving on to our next slide. So now for warfarin. You have already heard a lot about warfarin in Block 4, but remember the vitamin K dependent clotting factors require a maturation step where gamma-glutamyl carboxylase utilizes the reduced form of vitamin K to catalyze this step, leading to the formation of fully mature and synthesized clotting factors to then feed into the clotting cascade, ready to be activated. So vitamin K is oxidized in the process and must be returned to its reduced form to complete the cycle again. And this is carried out by VCOR-C1 or vitamin K epoxide reductase, which is going to be the target of warfarin. So by inhibiting this enzyme, we never get fully mature forms of our vitamin K dependent clotting factors, which are 2, 7, 9, and 10, where 2 is also known as thrombin. And without mature forms of these clotting factors, we end up with our anticoagulant effect. So now I'm sure you remember, but warfarin, despite its long history as an oral anticoagulant compared to these newer agents on the previous slide, it comes with a number of concerning pharmacologic considerations that I could fill an entire video for. But as I said, we covered many of these in Block 4, so we will just briefly revisit them now. So first, warfarin is a narrow therapeutic window drug. But instead of measuring warfarin levels directly to monitor drug therapy, we use INR to do this. And for most indications, the INR should be between 2 and 3. So again, narrow therapeutic window. And a high risk of falling out of this therapeutic range, leading to the risk of thrombosis or bleeding, depending upon which, if we go beyond the effective or toxic minimum concentration. So warfarin also has a very long half-life of about 7 days. So it will take 4 to 5 half-lives to reach a steady state therapeutic concentrations. So switching from that IV or sub-Q inpatient anticoagulant, like a low molecular weight heparin, to warfarin is going to be much more complicated and will require bridge therapy, where the other agent is given until warfarin therapy leads to a target INR within the therapeutic range. So we're going to have two agents basically overlapping, which complicates things for patients once they're discharged from the hospital. So this long half-life is also a problem for those requiring emergent surgery or those that experience a significant bleeding event. And this will require the administration of vitamin K, but it's going to take time for that vitamin K to lead to the generation of mature clotting factors. So this will have to be administered with 4-factor prothrombin complex concentrate, also known as PCC, which will provide clotting factors as we wait for the vitamin K to kick in. Also remember that there are a slew of drug interactions that risk throwing the patient out of the therapeutic window, like with CYP2C9 and 3A4 inhibitors and inducers, as well as antibiotics that are capable of altering the gut flora and its vitamin K synthesis actions. And don't forget, there are also those pharmacogenetic concerns regarding VCORC1 and 2C9. And patients will also have to be counseled to try and minimize any changes in their diet so that the amount of vitamin K intake in their diet remains pretty consistent. And they're also going to have to be counseled on the fact that they will need frequent INR monitoring. So these are the pharmacologic consideration highlights for warfarin, which will still be seen in clinical practice because of its long history of use, and some patients are well maintained on this therapy. But these highlights are why the other oral agents were developed to provide safer alternatives. Moving to our summary slide. So I hope this video has introduced you to the different mechanism of actions of the diverse array of anticoagulants available and how these fit into the clotting cascade when it is being pathologically activated or our patients are at a high risk of blood clots. So our discussion has also highlighted the pros and cons of each agent or group of agents, and I hope this will help you select the appropriate anticoagulant regimen based on patient-centered factors and help you to counsel patients to promote adherence and minimize the risk associated with anticoagulant therapy.